Hi all. In this session, we will discuss about the pharmacokinetics, particularly on absorption topic. Coming to the definition of the absorption. It is the movement of the drug from its site of administration into the circulation. So this absorption may take either by the passive diffusion method or by carrier mediated transport. Except the intravenous route, all other route the drug has to cross biological membranes. So the rate and extent of absorption varies with the route of administration. There are various factors that affect the absorption: aqueous solubility, concentration, area of absorbing surface, vascularity of the absorbing surface, routes of administration. So first let's discuss about the aqueous solubility. When the drug is given in solid form, it must first dissolve in the aqueous phase before it gets absorbed. So when it is given as a solution form, it is absorbed faster when that same drug is given in solid form or as an oily solution. Concentration. The passive diffusion of the drug depends on the concentration gradient. So when the drug is given as a concentrated solution, it is absorbed faster than the dilute solution. Then area of absorbing surface. So the larger surface area, the faster is the absorption rate of the drug. Next, coming to the vascularity of the absorbing surface. So blood circulation usually removes the drug from the site of administration and maintains the concentration gradient across the absorbing surface. So when there is increased blood flow to that particular area, it decreases the drug absorption. Route of administration. Oral route. The epithelial lining of the gastrointestinal tract, which is lipoidal in nature, is the effective barrier to the orally administered drug. The acidic drugs becomes non-ionized in the acidic gastric juice due to its acidic pH, and they are easily absorbed from the stomach. So the examples of the drug that are non-ionized in the acidic gastric juice are salicylates and barbiturates. So the basic drugs gets ionized in the stomach pH, and so they are easily absorbed only on reaching the duodenum. So the examples for this type of basic drugs include morphine and quinine. The absorbing surface is larger in the small intestine, particularly due to the presence of the villi, and hence most of the drugs are easily absorbed from the small intestine. The particle size of the drug plays a major role in the absorption process because of the rate of dissolution. So for example, when the corticosteroids, digoxin, aspirin, these drugs are easily absorbed when they are given as in smaller particles. The presence of the food in the stomach also delays the gastric emptying time, that also delays the absorption rate. For example, there are certain drugs when given with the food constituents forms the poorly absorbed complexes. For example, tetracycline, when it is given along with the milk, it forms complexes with the calcium and hence it delays the absorption process. So there are few drugs that get well absorbed only on an empty stomach. The antibiotics such as ampicillin, roxithromycin, rifampicin are easily absorbed when it is given on the empty stomach. So there are few drugs that are well absorbed after the fatty meal. Lumefantrine, which is an anti-malarial drug, its absorption was increased only after the fatty meal. Usually, ionized drugs are poorly absorbed when it is given orally. Gentamicin and neochigmin are poorly absorbed, so they are given either through the IV route or through the topical route. Whereas the unionized drugs are usually lipid soluble and they are well absorbed from the GI tract. Therefore, lipid soluble drugs are absorbed faster and better while compared to the ionized drugs, because these lipid soluble drugs gets dissolved in the phospholipids of the cell membrane. So there are certain drugs that are degraded in the gastrointestinal tract and they are ineffective orally. For example, penicillin G, which is get degraded by the acidic gastric juice, whereas the insulin, which is degraded by the peptidases. So for these cases, entry-coated tablets and sustained released preparations can be used to overcome these deficiencies such as acid liability, gastric irritancy, and longer duration of action. Efflux transporter P-glycoprotein is present in the gut epithelium and it reduces the absorption of the certain drugs because a small fraction of the absorbed drug is excreted back into the intestinal lumen. For example, digoxin and cyclosporine. So there are some drugs such as verapamil and quinidine that inhibits the P-glycoprotein, and also the drugs such as rifampin and phenobarbital enhances the P-glycoprotein so that the absorption of the drug gets reduced. The absorption of the drug can also be affected by the other concurrently ingested drugs because of the formation of the insoluble complexes. For example, tetracycline and iron preparation, when it is given along with the antacids and calcium salts, it forms complexes that reduces the absorption. So these type of interactions can be minimized when these drugs are administered at 2 to 3 hours intervals. Drugs also alters the absorption by gut wall effects such as changes in the motility or by causing the mucosal damage. For example, tricyclic antidepressants, opioids, anticholinergics are the drugs that retards the GI motility, whereas metoclopramide, which is an anti-sickness medication, is used to increase the gastric motility and also speeds up the food passage through the gastrointestinal tract. Neomycin, methotrexate, vinblastine. These are the drugs that causes the mucosal damage. Next, we will move on to the subcutaneous and intramuscular route of administration that retards the or alters the absorption rate. Usually, the lipid-soluble drugs crosses the surface of the capillary endothelium very easily. So, most of the drugs which are not absorbed orally are usually absorbed parenteral route. So, absorption from the subcutaneous site is slower than from the intramuscular site because both are generally faster and more predictable than oral absorption route. For example, depot preparations such as benzthiazine penicillin, protamine zinc insulin, depot progestins are usually administered by intramuscular route. Topical route. Systemic absorption of the drug after topical application depends on the lipid solubility of the drugs. However, only few drugs penetrate through the intact skin. The drugs that includes in this category are hyoscine, fentanyl, GTN, nicotine, testosterone and estradiol. Corticosteroids applied over extensive areas of the skin can produce systemic effects and pituitary adrenal suppression. Corneal is usually permeable to lipid-soluble and ionized drugs. The drugs that are applied as an eye drops may get readily absorbed through the naxolacrimal drugs. Example for this type of category is the timolol eye drops. Mucous membrane of mouth, rectum, vagina absorb lipophilic drugs readily. For example, estrogen cream is usually applied through the vaginal route. The two important factors that are involved in the measurement of the absorption of the drug are bioavailability and bioequivalence. First, we will discuss about the bioavailability. It refers to the rate and extent of absorption of the drug from a dosage form that reaches the systemic circulation. It is also called as a measurement of the fraction of the administered dose of the drug that reaches the systemic circulation in an unchanged form. Usually, 100% bioavailability can be achieved only when the drug is given through the intravenous route. The main two reasons for the low bioavailability after the oral ingestion are the drug may be incompletely absorbed or it may undergo first-pass metabolism in the intestinal wall or in the liver, or the drug may get excreted in the bile. The first-pass metabolism is the one in which the drug gets metabolized in the liver and finally excreted before it enters into the systemic circulation. The various parameters that are used to measure bioavailability are peak plasma concentration, time for peak plasma concentration, and area under the curve. The peak plasma concentration refers to the intensity of the biological response, whereas the Tmax is the rate of absorption of the drug from its dosage form into systemic circulation. Area under the curve indicates the absorption of the drug into the blood in a specific period of time. It is usually measured as μg/r per ml. Let's see one example for the calculation of the bioavailability. Usually the bioavailability is calculated to identify the plasma concentration of the drug against the time for any two or more formulations. So here this graph represents the bioavailability parameters of the two formulations which is having same analgesic activity. Here the Cmax shows that the analgesia produced by the formulation A is faster than that of the formulation B. So when seeing about the minimal effective concentration and minimum toxic concentration from this graph, it was assumed that formulation B is more safer than the formulation A. That means the formulation B shows prolonged effect as it maintains the minimum effective concentration of the drug in a plasma for a longer period of time. Next, about the bioequivalence. It is the term that is used in the pharmacokinetics used to access the in vivo biological equivalence of two proprietary preparations of a drug. So according to the FDA, the bioequivalence is defined as a terminology in which when the relative rate and extent of absorption of a drug from two or more similar dosage forms are equal, they are said to be bioequivalent. Hope you all understood about the absorption of a drug.